All right, welcome everyone to the New Jersey Birth Equity Funders Alliance Medicaid Waiver Training. My name is Cecile Edwards, and I am the Senior Manager of New Jersey Birth Equity Funders Alliance, or NJBEFA, which is a collaborative of 6 funders supporting the Nurture New Jersey plan to make New Jersey the safest place to give birth. NJBEFA values community first to make decisions that impact communities. And as a part of NJBEFA's strategic priorities towards these ends, we have identified advocacy and organizing as a critical component to sustainable progress around the elimination and reduction of Black maternal mortality. Our theory of change asserts that supporting CBOs closest to the ground doing the work to assist the most vulnerable can catalyze and ground our shared goals to achieving full birth equity. Identifying strategic avenues for engaging and impacting policy formation leads us to this training on Medicaid 1115 waivers. This waiver provides the opportunity for communities to assert critical priorities that impact the populations they serve. And NJBEFA seeks to assist the community in strengthening their advocacy voice by further orienting the birth equity community with Medicaid history, specific terminology, and rules that might help advocates better formulate and articulate changes they would like to see. Our goals for today are to provide basic understanding of the Medicaid program, history, structure, benefits, strengths, and weaknesses, to share ongoing opportunities for advocacy to improve the Medicaid program, and to share specific opportunities for advocacy to implement New Jersey's 1115 waiver, especially the provisions related to birth equity. To guide and teach us today, we have 2 phenomenal women advocating policy change. First, we'll have Elizabeth Lee, who is a principal at consulting firm Venn Strategies, where she leads their health policy work. She is a former Obama administration official at the Department of Health and Human Services and worked on Capitol Hill earlier on in her career. Tatiana Smith is a Haitian American full spectrum doula, birth justice advocate, food activist, product designer, and homeschool mom living in Jersey City. She runs Doulas for the People, a perinatal doula agency serving families in northern New Jersey. She supports digital initiatives as part of U.S. Digital Service, a division of the White House, and was most recently a recipient of the 2023 Jersey City Women of Action Award. So I am going to turn it over to Elizabeth and Tatiana to provide our training. Thank you both.
Fantastic. Tatiana's also wearing the most amazing yellow color, which is like brightening up my entire screen. Thank you. All right, I'm going to go to the slideshow. Can you guys tell me, do you see, no, you see the wrong thing, right? Now do you see the slides? Okay.
Yes.
Great. Thank you, Cecile. I'm going to skip the first couple of slides. All right, so this is the basics of Medicaid. And I can say, as Cecile said, I've done health policy for a very long time. I'm a little older than I look, and Medicaid is by far the most complicated and most confusing health policy topic I've ever worked on. So bless you all for even being interested in learning about it. So we're going to start with the very basics. And Tatiana, do you want to ask our first sort of like opening question to try and get the discussion started?
Sure. So the first question, what is Medicaid? So thinking about Medicaid, what is the first word or 2 that comes to mind when you think of Medicaid? And you can type in the chat or you can come off mute and just kind of give us your thoughts on that.
Hi, everyone. I don't mind jumping in. My name is Armini, and I work at the New Jersey Healthcare Quality Institute. When I think of Medicaid, I think of the term eligibility because it's not for everyone. There's specific criteria in order to be enrolled in Medicaid. And also just thinking of like the public health emergency, how it's coming to an end, you know, we have to reconsider eligibility as well. So I think of that when I hear Medicaid.
That is such a nice tee up for my upcoming slides. Thank you very much for that. Any other words?
We have some other in the chat. I'm just trying to see if there's other responses. No, I haven't seen any.
Yep. So Kathy said, helping those who need it. So that's another response we have there. And insurance to provide better health for patients. State is another response. And Jennifer, thank you. Government assisted insurance, Michelle. Gabrielle Caldwell. And Jill says access.
Great. And Jay, great question. We're going to get to that one too. Okay, those were such perfect words to tee us up for the next section. So thank you guys. I wanted to start with 5 things to know. So this is like if your mom or your cousin or whatever asks you and you want to sound smart about Medicaid. So it is different than Medicare, right? 2 very big insurance programs, but very, very different. Medicaid is a partnership between the federal government and each state, and it varies a lot state to state, who's covered, how it's covered, and how the program runs. But its primary focus is low-income Americans who have no other options for coverage. And it's a pretty big program. Right now, it's on the upper end of its total coverage ever. We're about 1 in 5 Americans covered by Medicaid. So it's a really significant source of healthcare access for a lot of Americans. So quick side-by-side Medicaid, Medicare. My husband can never remember, so the mnemonic I give him is aid for low-income people, care for old people. It's not perfect, but it helps you remember. Medicare over the age of 65. Generally speaking, if you're over the age of 65, you go to the doctor, Medicare pays. It's a federal government program. It covers a key set of benefits. You do have some cost sharing, whereas in Medicaid, they really try and limit that. But Medicaid is a little bit more unpredictable in terms of who's eligible, what it's going to cover, et cetera. And we'll get more into this, but they are 2 totally separate programs. There are a subset of people who are eligible for both. They're usually folks who are low income and have disabilities and have been disabled for a long time. There are some of our highest needs Americans. So we'll get to those later, but they are 2 different programs and their advocacy works in different ways for both. So I want to start a little bit of history. So health insurance actually was not a thing. You guys might remember this from like high school history, but in the 40s, they offered it as an incentive in a tight labor market. But if you weren't employed or your employer didn't offer benefits, insurance was out of reach. So the federal government tried to start to like put together some patchwork programs to close the gap. And in 1965 is when Congress said, okay, we're going to debate these new federal programs for low income and older Americans. The southern states didn't like that idea. They were already pissed about civil rights legislation getting passed. They didn't want a federal overreach. So the federal state partnership is actually a compromise to placate the southern states. So there is this very racist history of the southern states not wanting to have a federal program to come in and take care of the folks that they were unwilling to take care of. So it was a compromise sort of even from the very beginning of the program. So this is a quick timeline. 1935 is when the whole Social Security Act gets passed. Social Security is a foundation for these programs. 65 is when they're created. It takes almost 20 years for every state to agree to participate. Arizona was the last one. Then there's been some expansions of the program, pregnant women, kids, the Affordable Care Act that we'll talk about, and then some recent controversy around states that want to add work requirements into the Medicaid program. Eligibility, this goes back to your keyword. So I wanted to start with who does this cover? Who does the Medicaid program cover and serve, and who is it meant to serve? So federal law requires that states have to cover certain individuals, kids, pregnant women, and adults under a certain percentage of the federal poverty level. And then states can kind of build from there and they can add on other additional populations. Children, individuals with disabilities, and seniors are usually eligible in most states, but it varies in terms of their income eligibility. So the core group of folks that are eligible for Medicaid is actually pretty small. So it depends on the state and sort of how generous they are, how generous their legislature is in terms of how they have expanded the program over time. So who is enrolled? This is 2021 data. You can see this here. It's a very diverse set of Americans who are covered. It is a majority under 100% of federal poverty level. It's disproportionately female by a little bit just because pregnancy is a qualifying condition for coverage. So you tend to see more, it skew a little bit more female, but it's a really, representative cross-section of the United States. So who are a few communities that really benefit? So 1 of every 3 kids in the US, 70% of low-income children are covered by Medicaid. 40% of all births, that has varied over time. It has gotten up to 50%, but it just means for the purposes of our conversation, it's a great policy lever because it covers so many different births in so many different parts of the country. 2 out of every 3 nursing facility residents, and 50% of folks living with HIV who are receiving care. So people who are the most vulnerable or at the most vulnerable parts of their lives oftentimes will benefit from Medicaid coverage and access. Okay, so then Obamacare came along in 2010. The idea was a universal coverage. So one of those was Medicaid, and they wanted to incentivize states to expand their Medicaid programs. However, some people sued over that. And in 2012, they changed it from a mandatory Medicaid expansion to an optional Medicaid expansion. I probably don't need to tell this group that Medicaid expansion is a good thing. Studies have demonstrated super, super positive results in terms of access to screening and preventive care and managing chronic disease. But despite all of that overwhelming evidence, 12 states still have not expanded Medicaid and refuse to sort of accept the benefits and the federal funding that come with that. We are slowly toppling them one by one, but those last 12 are probably going to prove even harder. And then unwinding, as you mentioned. So at the beginning of COVID, they said, the federal government said to states, we will give you more money to handle COVID, but you can't kick anyone off your Medicaid rolls. So for 2 years, there was a 21 million person increase in Medicaid coverage. And then in 2022, Congress said, okay, this is all going away now. COVID money is going away, and you can resume kicking people off of Medicaid and doing these eligibility redeterminations. So there's been a bunch of different estimates about how many people will now lose coverage, but it's in the millions, somewhere between 10 and 15 million. New Jersey, which we'll get to, just started their process in June. So you'll see folks lose coverage off of Medicaid and have to either go into the exchanges or find other ways to gain healthcare access. But it is a huge undertaking that states have really never had to go through before, because they usually do eligibility redeterminations, quarterly, regularly. This is a huge undertaking and a major disruption in a lot of people's healthcare. So I think we'll be seeing the ramifications of that for quite some time. Okay, so this is our next pause. Interested in your all's view on, do you think that Medicaid should get bigger? Do you think it should cover more people, and why or why not? Me too. Yeah.
Humans need health insurance, period.
I know, I like that one.
Yeah, I would say in lieu of expanding Medicaid, how about we just have universal health care? But I guess that's probably a different webinar.
That is absolutely, Jennifer, always my thought. So.
Next webinar, we'll do that. Just
That's right. I will be happy to join you again for that one. All right, so the next part is, okay, so what does it cover? Now we've talked about who's in it, what does it cover, and how is it covered? So we're going to talk about benefits. So optional and mandatory benefits. To participate, each state has to offer a certain core set of benefits: hospital, home health, physician, community health center. And that's really it. For beyond that, they add on top of that as optional benefits. So things that you might not expect to be optional. So physical and occupational therapy, home and community-based services, if folks need to come in your home and give you support, dental, and unlicensed provider services, which is a category that includes doulas, community health workers, anybody who's doesn't have a licensure process with a state board. So these are, the mandatory benefits were created a long time ago, and before a lot of these things had sort of been integrated into the healthcare that we all know now. So there's a really small core set of benefits, and then it's up to every state to expand based on their residents' needs. Okay, so this is where it gets a little complicated, so please stop me if anything's getting confusing. So to receive funding, states have to give those mandatory benefits. They cannot impose any waiting lists or caps. And then in response, the government funds every dollar for dollar. It's a federal matching percentage, it's called. And then states can add optional benefits through state plan amendments or waiver agreements. And then states get to decide how they purchase those services and how they pay the providers that provide the services. So the federal government really has a pretty light set of requirements to do that initial matching percentage, and then states build on from there. And they're really making changes to their programs all the time, as we'll talk about. So then managed care, which you guys probably know, New Jersey is a managed care state. So most states contract with plans, you know, the big health insurance companies, some are smaller, regional, to provide coverage to Medicaid beneficiaries at a capitated rate. So the contracting process is governed by the federal government, but the content of the contracts is not. So states have a lot of flexibility on how to pay managed care companies, how to build those rates, how to hold them accountable for the things that they're doing. There's not a lot of federal oversight in that. That is really state by state. The only federal rule is that MCOs have to spend 85% of their rate on medical costs and only 15% for profit and other administrative expenses. So then providers come in here. So the MCOs then build their networks of providers. So they then can establish value-based care contracts with those providers that we'll talk about. But the plans get to say, you know, this hospital, this group of doctors are in network for our plan. And so we're going to steer Medicaid beneficiaries in that direction. And there's usually, New Jersey has 5, some states have, you know, dozens of different plans covering. And so you as a Medicaid beneficiary are then assigned, you could pick or assign to one of those plans to provide your coverage. So the types of provider payments that I referenced, this will come up later. So some are fee for service. That's when, you know, you just bill each service. There's no requirements around it. It's just it's a volume-based business. Value-based care is pay based on the quality of the care provided rather than the volume. And that's where nationally the federal government is really pushing states to do more of that and hold providers accountable for the care that they deliver to beneficiaries. So with more flexible payment, oftentimes providers do better because they can collaborate and they can do things that might not be covered otherwise and do work that isn't necessarily billable on its own. So there's huge potential for, especially in the maternal and child's health space, this kind of payment to really open up a whole new set of services. Yes, Jay.
Hi. So for value-based care, I don't know this, I'm just asking, is that a space where doulas are falling under to be covered by Medicaid as a value-based provider as opposed to fee per service?
Tatiana, you'd know better. I don't believe so in New Jersey.
No, so value-based service, and we're going to talk about that. It's like a bundle. We're going to talk about that later, but it's separate from fee for service where you're billing out like per prenatal, per birth, per postpartum. It's
Right.
just set up a little bit differently. So no, it's not the same.
Okay, thank you.
Yeah. Okay, so this is just a little recap of the key players. So federal government set those foundational requirements that I talked about. They provide the matching funds that allow states to grow their programs. The state then has a lot of decision around benefits to add, how they reimburse their providers, if they want to run it all through a managed care organization. There are some states, not New Jersey, that actually don't use the managed care at all and just pay providers directly, but that's getting less and less common. So, but all of these entities are really key in the delivery of care, and they all have different layers of oversight and accountability in order to deliver that care. I think we're to our next question, Tatiana, if you want to pose it.
Sorry, I was on mute. What do you think would be most impactful to advocate? The federal government, state, or with private plans administering the program?
This is Jennifer Santos. I've actually done some of this advocacy, and I would definitely say federal government and then state, because the plans don't care. We've met with them as the New Jersey chapter of the American College of Nurse Midwives. The federal government has a little bit of a say, and right now in New Jersey, our state government is pretty open to hearing about what we have to say. Mm-hmm. I'm sure a lot of us have listened, so I have noticed. So I would say that I wouldn't waste too much time on conversations with the plans, but the federal and state governments have been very receptive.
Yeah, I would agree. So to get the funding, I would say definitely federal. I'm sorry, am I giving you an echo? Sorry about that. I'm gonna switch, but federal to get the funding, but then to make the local impact, it's really gonna have to really home in onto the state governments. The MCOs, they kind of do whatever they want to do because they've already gotten the money, and so they're privatized, even though they are nonprofits, and they're kind of really just doing their own thing. So it's really going to be up to the state governments to really hold those MCOs accountable so that they do the right thing with the money, and for providers and for families.
Yeah. And it gets to Jill's question about MCOs and the providers. I mean, they're really doing those negotiations on rates as private businesses. I mean, New Jersey and other states really delegate that task to the MCO. I mean, in the simplest terms, they're saying, okay, for this kind of a beneficiary, we're giving you $10,000 a year, like, figure it out on your own. Make your provider payment, negotiations, like you have to meet certain quality metrics, but they leave a lot of those sorts of like business negotiations to the plans and the providers independently. And so it leads to your point, a lot of variation across the state in terms of like providers not getting fully compensated for their work, not wanting to participate, not wanting to take a lot of Medicaid patients. So it causes a lot of issues. Okay, so now we're going to get into exactly how the states change their Medicaid programs, which will tee up our conversation about the 1115 waiver. So I talked about the fundamental, here's what the feds require, and then states build from there. So states can do state plan amendments or they can do waivers. So state plan amendments is a change to the plan that is basically any part of your plan for everyone in it. So I want to add a new population. I want to add a new benefit. I want to increase, baseline provider payments. You submit that to CMS and they are supposed to get back to you within 90 days. And a lot of them are very straightforward. We want to increase the rates for nursing facilities. Others are, a lot of states now are doing extending to 12 months postpartum. Like we want to cover pregnant women to 12 months postpartum. And those are relatively, because they're within regulatory sort of bounds, it's usually approved pretty quickly and you go back and forth with CMS. Waivers tend to be a little bit more complicated because you're asking CMS, you're asking the federal government to waive certain requirements of Medicaid to try something new. So that relates to managed care, also home and community-based care, and some others. It also can't incur any new spending. So you're usually moving money around or changing the way you do payments in order to keep it cost neutral. The waivers can take a long time to get through CMS. They're usually more ambitious projects, but they also have the potential to do a lot more and do a lot of really creative and interesting things. So I think I covered a lot of this. They filed the state plan amendment with their regional office. They cannot go back, right? They can't change any mandatory benefits. They can't lower eligibility below the ACA standard. So you can't further reduce your Medicaid program. And generally speaking, it's the administrative aspects of your Medicaid program. Tatiana, do you want to talk a little bit about the doula spot?
Yeah, so I think a lot of folks in the room, and I see some chatter in the chat box about the SBA for doula care. So in 2021, New Jersey filed SBA 20-0011, which added doula services to provide support for pregnant individuals throughout the perinatal period. So giving them prenatal labor support and postpartum support, and then there's enhanced support for those for a certain age. The states did not set rates for the amendment, but specified the following services to be added. So the counseling and education, including infant care to prevent adverse outcomes, labor support, as I said, and then coordination with community-based services. So all of those are not necessarily part of the SBA, especially with community-based services. It's really focused solely on the doula, and the doula has kind of been tasked with doing all of these tasks. So, but it is a start to get folks the care that they need. There's a lot of work to be done, and we'll talk about the advocacy opportunities that there are for this SBA. But this is just an example of an SBA.
You have to, if you change it, so doula is a good example. If you add a benefit like doula services, it has to be open to all Medicaid enrollees across the state. You can't just say it's only open to certain subsets of women. You have to say that everybody is going to have access to it. And it's also regardless of their eligibility category. So there's a lot of like equity provisions built into these state plan amendments and the way that CMS approves them. Medicaid enrollees, this is an important point that I forgot to mention. There's a freedom of provider choice requirement from the federal government where you have to be able to freely choose your provider. So this runs into MCO issues all the time. But it's really important when it comes to matching up patients with their best providers. And CMS, when they have the full resources to do enforcement, have come into states and given them, penalties for not meeting this requirement. It's something that comes up a lot because of the lack of participation from some providers in Medicaid. So it's a perennial issue in terms of running Medicaid programs in various states. Okay, so now on the waiver side, so a waiver allows to waive certain regulations. They are time limited. So they're saying we're going to test this new payment delivery system reform requirement for 3 to 5 years. I mentioned the cost neutral, but they obviously have to be consistent with the Medicaid program. Now, I will note, I'm sure you've heard my bias already, but I will note that different administrations interpret this differently. So for example, the Trump administration solicited waivers to require a work requirement, to include work requirements in Medicaid. So it really depends on who's president and running the Medicaid program at the federal level, what the purpose of the Medicaid program is. During the Biden administration, they're much more interested in waivers focused on health equity and maternal health. And so there's a lot of different push and pull from CMS on what kind of waivers they're really looking for, depending on who's president, stating the obvious. So 1115 waivers in particular, they're experimental or pilot programs. They're evaluating policy approaches to improve service and care. They have to have a public engagement component. They have to have a 30-day notice and comment period. There's usually multiple if they go through multiple rounds of edits. They're generally 5 years, but they can be extended or renewed with changes. Okay, this is teeing up Tatiana's section, but if you guys were going to change one thing about Medicaid in New Jersey, what would you change?
Require more providers to participate. So that is a very loaded statement coming from someone who is a provider and participates.
And I am too, but I'm also a parent and I've seen both sides of the coin.
Yes, I am too. Both.
Yep. I'm a parent of a child who receives NJ family care. And so I have seen how limited it is.
Yes. So I just want to talk about with someone posted a question. Alexia, you asked if is there a standing recommendation that the doctor must complete for the doula to bill? So every time a doula gets a new client, they have to they are asked to fill out. I'm sorry, can someone mute?
Yeah.
What does that mean?
Erica.
So they have to fill out this recommendation form for doula care. They don't need to go to their doctor or their primary care physician. They can really find any other person with an MPI to fill out that recommendation. Because what we've seen is that some doctors are reluctant for doula care, and so they may not want to sign it, or some doctors don't understand what it is that they're signing and the implications on their practice, so they might not want to sign it. But they are required to have this recommendation on this file. They don't have to submit it anywhere, they just have to have it on file. And I did want to respond a little bit more to the requiring providers to participate, Jennifer. So yes, as a provider and as a mom and as someone who has previously used NJ Family Care for my child, I understand both sides of the coin. The problem is really with the insurance. The insurance companies that make it incredibly difficult to bill, to receive reimbursements, and to just do their practice. And so the untold story is that a lot of these providers are getting burnt out. They are quitting, they are dying by suicide because of the workload that is imposed on them by these medical systems that are not aligning with their Hippocratic oath to provide the care that they need to their patients. And so I understand that we want more providers to participate, but when these insurance companies make it so incredibly difficult to participate, and then the states kind of like give them free reign to kind of run their organizations however they want to, that makes it really challenging for a provider to give the care that they ought to be giving. Higher reimbursements for providers. Yeah, we see that across the board. Not only doulas get an incredibly low reimbursement rate, but also other providers get a low reimbursement rate. Provide enrollment and parity and reimbursement, create the conditions for providers to stay on board, definitely.
Yeah.
Smoother process to enrollment and contract. HMO needs to approve more providers. They make it incredibly difficult for enrollment. A lot of providers, at least from the doula end, I've seen them just kind of stop halfway because it's just so difficult. Horizon and J Health's contract's about 82 pages long, and that's only one piece of information that providers have to fill out. They have to fill out multiple forms, and a lot of the forms are not even relevant to the practice, but they still have to fill it out as a course of process. Yeah, the hoops necessary to become a doula provider, ease and education of the process, definitely. Jennifer, so I changed my answer. Unprivatized Medicaid, yes. Universal health care, yes. Ease in billing, high reimbursements. I would add to this, there needs to be an alignment with government and the MCOs. So we've seen that the policies that have been announced by the government don't necessarily align with the policies with the MCOs, or they are unaware that the government has made that announcement. And so it creates a discord between providers and the MCOs. Like, you know, the government said this, but you're saying this, and you have a different policy, and I'm not getting paid what they said they were going to pay me, and you have different rules. It makes for a lot of chaos. And ultimately, who ends up suffering is New Jersey families.
Yeah. Can I just underscore one thing Jill said before I turn it over to you, Tatiana, is that this is something that I had in there and cut for time, but there's an interesting interaction between state government, like legislature, and decisions that the Medicaid program makes. So there are times where the legislature is actually really interesting. It's not the focus of this webinar, but it's a really interesting place to advocate, because the legislature can always force the state to do something. So they can say, you have to add doula benefits, and then the state has to file the state plan amendment. A lot of times it comes from the Medicaid office, but there are times where you have, you know, a friendly-ish legislature, and you can work together with them to say, we're asking you to add this benefit, and we're also giving you the resources to fund it, you know, for the next calendar year or what have you. So there's always this interesting interplay with the legislature. And there are other states besides New Jersey where they actually have to get, like in the state of Wisconsin, for example, they have to get legislative approval from their state government before they make any changes to their Medicaid program. So that process actually changes a lot state by state. So New Jersey has a relatively friendly relationship between the state government. I don't know if this will always be true, but right now between the state government and the legislature, such that you can use both in your advocacy efforts. And now I would turn it over
I want to also, I missed this comment that Jay mentioned about adding more benefits for mental health providers to participate. So definitely mental health needs to be a part of these wraparound services, and we can probably talk about it in the, Jay, actually, Jay, do you want to speak to what you just posted? Are you able to?
Yeah. No, I can talk. I was trying to be concise. So like we've been seeing a large increase in moms who are asking for support even before postpartum. And they're looking for like very particular things, right? Like someone who has experience with dealing with pregnant and postpartum women or birthing people. Also someone who looks like them, which is a whole nother thing, right? And having the ability of not being criminalized for asking for that support, right? So we've tried to build our own, like we've built a lot of partnerships and relationships with different people and providers. But whenever we have found providers that fit that criteria, that understand the community, that look like the community that we're serving, that have the credentials, they're incredibly hesitant to take on Medicaid clients because it will end up being almost like you're doing it for free because of the reimbursement rate and the level of severity that a lot of these families are walking in with. It makes it like even less of an incentive for them financially to take on that level of burden. And then they become like a martyr of like, okay, I'm the one Black or brown provider that's helping these 12 people, but then, you know, my practice can't sustain itself with these 12 people because my reimbursement rate is $4. Like, it's ridiculous, you know? So it makes it more and more difficult for providers of color to really be able to help communities that really need them, that are looking for them specifically because of that identity factor. Does that all make sense?
Absolutely.
Like the one thing that still blows my mind is like we had one mom in particular who was having a lot of severe issues, and we were literally like hand holding her, trying to get her into care, calling hospitals, calling mental health providers, doing all this stuff. And they were just like very like nonchalant, like, well, have her get on the waiting list. She can wait for 3 months. She can wait for 6 months. I'm like, no, she can't. Like, well, if she's that bad, have her check herself in so we can evaluate her inpatient. I'm like, well, then who's going to take care of her kids? And then it becomes this whole, again, the criminalization, like, well, if she's that bad, then maybe CPS should take her kids. So it's like, we can't keep doing this like give and take. It's like, you're going to provide the service, you're going to help this person, give her the equity that she needs to be able to participate fully without having repercussions for saying, I know I need help, you know? So it's become such a bigger issue than it really has to be because of all this other red tape that Medicaid creates around utilizing it as an access point. Does that make sense?
Yeah, absolutely. There's so many barriers that come with, so you're receiving this benefit, but also there are all these sort of checkpoints that are meant to kind of appease. It's really, those checkpoints are meant to appease certain legislators, certain people that are in the constituency, but they actually harm the actual individual getting the benefits, and it might even keep people from receiving the benefits that they need.
Right. So what do we do? Sorry,
we're gonna talk about advocacy in this section, but I just want to get through just talking about Medicaid in New Jersey, where we are, what it means for us, and what's involved. So just to give an overview of Medicaid in New Jersey, there's NJ Family Care, and that covers children under 19, adults, and pregnant women. And then there is another section of NJ Family Care for the age blind and disabled, and that covers people age 65 and older, and people determined to be blind or disabled by the SSA or by the state of New Jersey. So what does this break down to? What are the demographics? NJ Medicaid enrollees in Medicaid programs totaled about 2.3 million, the 12th largest state in terms of Medicaid enrollments. By October 2022, 57% of New Jersey Medicaid enrollees were people of color, and non-ABD New Jersey Medicaid covers about 965,000 children and 1 million adults in the state. So some important things that have happened with New Jersey family care with New Jersey Medicaid. New Jersey was one of the first states to adopt the Medicaid expansion in 2014 under Governor Chris Christie, but he made a provision that federal funding must cover at least 90% of the additional costs for the expansion. So he previously vetoed the bill, but so he would only allow it if it had that specific provision. So these are the types of things, like they'll pass these laws, they'll pass these amendments, but then they include special provisions to appease certain legislators or certain constituents. In January 2023, Governor Phil Murphy announced that children under the age of 19 whose families meet income eligibility, they are now eligible to enroll regardless of their immigration status. And then, so in April, the public emergency status, it ended. And so the Medicaid disenrollments are beginning to happen, and officials expect it to drop by 13%. So how well does NJ Family Care serve the people that are receiving this benefit? So let's look at some of the maternal and child health outcomes. 20% of 2022 births were covered by Medicaid. About 76% of women on New Jersey Family Care delivered a live birth and had a postpartum care visit on or between 7 and 84 days after delivery. In my personal experience, I've seen more and more families, they're seeing their providers within 4 weeks of delivery. Like instead of waiting for that 6 weeks, the time that they meet is coming earlier and earlier. Since Medicaid expansion, the maternal mortality rates have dropped. We still needed to drop more. We know everybody here on this call, I think, knows what those statistics are. They could be better. From 2012 to 2016, New Jersey had 36.2 maternal deaths per 100,000 births. And then from 2018 to 2020, this number dropped to 24.1 maternal deaths per 100,000 births. Still too many. Chronic disease, about 92% of New Jersey Family Care beneficiaries had an outpatient visit with a BMI documented in their medical record, and that's an indicator of care access in the state. So we know from working in the community that it's really important that doctors notate those specific illnesses in their charts, because when it's not written down, then it doesn't get taken care of. So just the fact that they're notating it is an indicator that people are getting the care or beginning to get the care that they need. And then about 56%, about 56% of enrollees aged 18 to 64 had a diagnosis of hypertension, and they adequately control their blood pressure through treatment. Still way too high. Over half of Medicaid enrollees have hypertension, high blood pressure. We know that definitely in the birthing community, a lot of moms, after they've given birth, they suffer with the hypertension, but in our communities of color, definitely high blood pressure, heart disease is a major chronic disease that is in our communities. And so we want to make sure that those people are getting the care that they need. Next slide. So how much does this all cost? New Jersey spent about $17 billion on Medicaid in 2019, and then that rose to about $19 billion in 2021. And since 2013, Medicaid has increased from 20 to 23% of the overall state budget. Experts predict that the spending growth on Medicaid for all states will decelerate to about 4.2% growth in 2023 due to disenrollments and slower enrollment growth. And on that previous slide, I talked about how the public emergency ended, and so we're starting to see that decline in enrollments. 2023 cost increases are due to a few factors: inflation, provider rate or cost increases, and increased expenditures for home and community-based services. So let's talk about value-based care in New Jersey. In New Jersey, the state relies on its managed care organizations to do a lot of this work with providers. However, the state has invested in value-based care for perinatal care, including the pregnancy episode of care pilot. Now let's talk about this pilot. It was a 3-year pilot to test a new alternative payment arrangement that that includes prenatal, labor, and postpartum services. The clinicians can choose to participate in the pilot, and they're financially incentivized to take on full responsibility for the quality and cost of the patient's care. And each pilot will tie incentives to improvements in quality and cost of maternity-related care from the prenatal period to 60 days postpartum. In addition to eligibility for additional financial incentives, providers who participate in the pilot, they get periodic feedback to make sure that they are working up to, and that there's accountability, and then there's quality improvement in what they do. So there's a difference here, just to go over the difference between like fee for service, MCOs versus value-based care. The MCOs are billing per service. So if you have a postpartum visit, if you have a prenatal visit, if you have a labor visit, those are each billed individually, and there's no sort of feedback mechanism for like how effective is that service that you're giving the client. The value-based care is more of like a package deal where you're tying in all this bundle of services, and then there is sort of a feedback loop of how well did these services serve the client. We can go to the next slide. So pending legislation to change Medicaid in New Jersey lawmakers are considering legislation that will require Get Covered New Jersey to automatically enroll people who lose Medicaid into a plan through the exchange. So if a person, this legislation, if a person loses their Medicaid coverage and they're not working and getting their insurance from their job, or they're not eligible for Medicare, then there's this legislation to kind of automatically enroll them into the health insurance exchange. And then the New Jersey Assembly is considering a proposal to raise the rate Medicaid pays for adult medical daycare services to about $90 a day per person, which is an increase of $3.44 over the current per diem payment. So I shared a lot. What surprised you the most so far learning about Medicaid, and what other questions do you have? Oh, so Jay, where does case manager fall in reimbursement through Medicaid? So there is no reimbursement, at least for doulas. As far as I know, for doulas, there is no sort of mechanism. Now, there is the community health worker pilot that it will reimburse, like it'll give you funding to reimburse community health workers, but it's not like a standard part of the Medicaid plan right now as it stands. So everyone who has an agency or is sort of doing case management, they're kind of eating those costs through their agency.
Oh yeah, because thank you, Raquel, because I know I've worked in a different capacity, but I've worked with other agencies that they particularly only took Medicaid clients, and they would have like, I won't say comorbidities, but they would have like co-diagnoses. So they would be pregnant and have, something else. But there's nothing that Medicaid has specifically around case management for reimbursement.
So I have not seen that. The only thing that comes close to it that I've seen and I understand is the community health worker pilot train those community health workers, and then later they become a part of the agency. Now, a lot of the agencies that do have those wraparound services are receiving funding from the government. So I guess in a way they're, getting reimbursed, but that's not like a one-to-one. It's really not the same thing.
Okay.
Yeah. I mean, and that's all I know. There could be more information out there, but that's what I know so far.
I just wanted to point out the response that Raquel made around that. As she stated that other providers can bill Medicaid for case management services, nurses, for example, and many mental health providers bill for case management as well. So I don't know if that's helpful, but yeah.
Yeah, that's what Jay was saying also. Yeah.
Yeah. No, I mean, I've worked as a case manager as a nurse, but I've also managed people who were not nurses who were also doing case management. So I didn't know like what the I guess like the back end thing of it was, because we all did billing, like we put in the codes and everything, the ICD-9, ICD-10 codes, but I just don't know, like now as a owner of an agency, I want to know what I'm supposed to do in order for us to do that. You know what I mean? So, yeah, I'm just not familiar with what that looks like.
This is not an expert speaking, but I think that what happens is a provider agency like a mental health clinic gets approved to provide case management services, and those services are billed by the agency that meets but not necessarily by individual. So you can't be like it's not approved for doulas, but there are, I'll find the Medicaid. There was a Medicaid state plan amendment. And for example, the CCBHC model, there are these community behavioral health providers who are allowed to bill for case management services. And then there are certain providers who've been approved specifically for mental health services that can bill for case management services in conjunction with the licensed clinical services that they're also providing.
Got it. Okay. Thank you. Okay.
Jake, may I ask, without diverting too much, does your agency have those other types of providers that can bill? Because it seems like you have to use those avenues in order to be able to bill.
So that's what we're developing. So we're trying to see
Yeah.
like what the structure is what structures are needed in order for us to bill. I know like we're setting up things now to accept health insurance, and like it's like the organizational billing, and then there's like the rendering provider billing. So what's it called? MPI. So we're trying to do we've gotten the MPI for melanated moms, and then we have to do an MPI too for a rendering provider. So I'm trying to figure out how many people or what are the structures needed in order for us to bill. But I didn't know if there was like something else. So, okay.
Yeah.
I think that makes sense. I get it.
Yes.
You ready to go to the next section, Tatiana?
Yes, I muted myself by accident, but yes, let's move along. So Medicaid advocacy, these are some opportunities to advocate. States are constantly making changes and improvements to the Medicaid program, and the advocacy can and should keep pace. So we should always hold the state accountable for the delivery of the Medicaid program for all beneficiaries. And while periodic opportunities offer clear calls for input, Medicaid agencies should consistently be seeking feedback from stakeholders. I will say to that, you will have to, as you're doing this advocacy, they'll have to be constantly called out. Don't wait for them to reach out to you. Next slide. On March 30th, CMS approved a 5-year waiver for the NJ Medicaid program called the New Jersey Family Care Comprehensive Demonstration. New initiatives focus on continuous eligibility, coverage expansion, and health-related social needs through several initiatives: the Behavioral Health Promoting Interoperability Program, targeted coverage of certain services that address health-related social needs, including food and transitional housing supports, and a community health worker pilot. The next step is for the state to begin implementing the new ideas that CMS approved, which provides an opportunity for feedback and support from stakeholders. So it's really important. We know that time is critical to get in on these work groups. We're already pressed as providers, as people who are working in the community, we're already pressed for time. But in order for these to get implemented in the best way, we do need to kind of take part in those conversations as best as we can. Then NJ 1115 waiver renewal highlights. So what is it? It's an integrated housing strategy for Medicaid beneficiaries that incorporates coverage for additional targeted services and coordination across state and community resources involved in the provision of health and housing services. Community health worker pilot focuses on overcoming health disparities within local communities, providing health care coordination services, and directly providing preventative or related services. 12 months of continuous eligibility to adults whose Medicaid eligibility is based on the modified adjusted gross income, increased coverage of nutrition services, and extension of full state plan benefits to postpartum individuals enrolled in Medicaid or CHIP for up to 12 months from the last day of the individual's pregnancy. So stakeholder engagement plans and meetings with stakeholders, New Jersey has made clear that while some policies have been approved, there are still several outstanding program components that we now need your help with before we transition from policy development to implementation. So before someone else makes the decision and decides how a program rolls out, we really need to be there to say, this works, this doesn't work. We need to have this as part of the program as much as we can, even if not all of the input is added to these new programs. We need to at least be able to say that we said something. In order to implement key provisions of the waiver, New Jersey State Medicaid is hosting a number of stakeholder work groups to determine program design. Move on. So what provisions support birth equity? 12 months postpartum coverage and flexibility to carve in behavioral health services so that they are integrated with primary care benefits. And what is not included? So housing is not included, but the final waiver approves traditional housing supports for individuals with a clinical need or who are transitioning out of institutional care, congregate settings, homelessness, or homeless shelter, or the child welfare system. But pregnant and postpartum beneficiaries are not specifically mentioned. And then there's the centering pregnancy, where there's no provisions included. So there are a few advocacy opportunities. So the New Jersey birth equity priority, they prioritize perinatal care integration, preventative services expansion, and alternative payment models. The perinatal care integration, we can work directly with the state Medicaid office to develop, pilot, and scale value-based models, payment models that prioritize integrated perinatal care. For preventative services expansion, we can help the department prioritize key populations and program design. And for alternative payment methods, we can help develop additional development of payment models, prioritizing maternal and infant health. Some more advocacy opportunities, community health worker pilot. So we need to work with New Jersey to ensure that perinatal community health workers and related training is included or required. And then social determinants of health, ensure equitable program design. And additional advocacy opportunities, doulas. So we discussed this earlier. New Jersey does cover doula services, but there are serious issues with implementation of this new benefit, including there's no backup doula coverage. The overall rate is too low, or it's not uniform across the MCOs. And there's just a host of other issues like enrollment. Some of you have brought up different issues with enrollment, how you get reimbursed. There's just several issues that we need to advocate for. And then since 2021, so the benefits started in 2021, and since then, New Jersey has not released any data yet on the impact or uptake of the benefit. So how many, we can find it, like how many doulas and agencies are involved, but how many families have been served, what type of services they receive. We have this data somewhere, it's hidden by the state. We need to hold New Jersey accountable and ask them for this data. And then we need to have an increased discussion from the maternal and child health community, including and especially doulas, could help move this conversation forward. So call to action, what do we do next? We need to set our advocacy priorities. So what in this that we discuss, or even beyond this discussion, what speaks to you and where do you want to raise your voice? We need to identify those areas of alignment with other people. So gather a group, and then you can decide on many different ways to advocate. So you can write a letter to government officials or people in charge, organize to meet with those advocates, and then then you can seek a meeting with officials after you've met and kind of come to a conclusion over the basic needs or that you were looking to advocate for. And then you can also join a stakeholder work group for the waiver implementation, which is time sensitive. And here is an email where you can send, I don't know if Cecile, if you can put that email in the chat, or someone can put that email in the chat to join the work group for the waiver implementation.
Yes, so yes, the Tristan.Gibson@dhs.nj.
Yes.
Is the email that you would email to do that. In our follow-up, I will provide, and that would have to be done by this Friday. We're actually but we'll give you some time here. So I'll put the work group names in the chat now. So
we can move on to our question and discussion time of this. We've kind of went through all of our slides, and now we open the floor up to you. We've had a great discussion in the chat.
Yes, so let me throw out the questions that were asked in the chat so that we can get people's questions answered. So and if they've already been answered, then we can just let me know and we can skip it. So the first question was, how do new organizations establish themselves as a billable provider with Medicaid?
So I know for doula organizations, you need to submit an application to the doula guides. There is a full, so I don't have the link in front of me, but there is an email that you would send to them. And basically you need to have 2 doulas who are, as an agency, those 2 doulas need to already have a Medicaid ID in order to become a doula agency. So you would need to submit your application and have those doulas with their MPIs and their information on the application. As long as you have 2, then you can start an agency. From then, after you get your Medicaid ID, then you can begin enrolling as go to the different MCOs and enroll as an agency. And it's a little bit, there's a few more other steps. I do offer training on how to do this, but that's the basic gist of it. You need to have 2 doulas who are Medicaid, that have Medicaid IDs in order to submit your application. Then you go through a series of steps to fulfill the application. And once you get your letter, approval letter, you get a Medicaid ID, and then you can go to the MCOs and apply for a contract with them. And then you can start billing.
Thank you. And I know, Tatiana, you have a training coming up, so please feel free to share the link so people can sign up for that and get all the details that they need. The next question was, what's the difference between home health services and home and community-based services?
I can take this one. So home health is like care, like the actual like nurses coming in and doing like care in your home, versus home and community-based services is more like assistance with activities of daily living. So like helping you take a shower, helping you like do like get meals ready, things like that. So there's a lot of crossover, but the home and community-based services, there's like sort of a tension between folks who need that kind of services. Should they be admitted to nursing facilities or should they get care at home? And not every state covers the care at home piece. But there are some like temporary home health where like you get discharged from the hospital and you need 6 weeks of home health care because you have a like colostomy bag or something. But like, so that's more of a temporary benefit that's offered, versus home community-based services, you're typically gonna need for the rest of your life.
And do we know if New Jersey has the home and community-based services?
Yes, they do. I don't know the extent of it, but I know they have a program.
Okay.
They have a very expanded and very rich and very progressive home and community-based service.
Great. And in that case, Elizabeth, even though it's an optional benefit that they've opted in for, do they still get the federal match?
Yes. Yes. Yep.
Thank you. So we have some links in the chats for the training, as well as for the requirements for doula, the steps for applying as a doula to receive that Medicaid. The next question is for Elizabeth. Elizabeth, can you talk about variation in rates for providers and why in MCO there is differences in what consumers should know?
Yes. Yeah, I talked about this a little bit. There's a huge lack of transparency on some of this in terms of what providers get paid and how they get paid. So as a consumer, you might not know when you're choosing your plan what those rates are. So it's another advocacy opportunity to know more about like, what will my choice of provider really be? And are your rates adequate, et cetera, because there's a lot of that sort of like private business negotiation between the plan and the providers about what their rates are, how they're paid, et cetera. I think it's a little different in New Jersey, but someone else should correct me, but like with Horizon being such like the dominant player, it just changes the dynamics because it's almost like they set the standard and everyone else follows along. So like for good or for bad. So if some states are more carved up like by region or such, but Horizon's like over 50% of the market. And so they tend to sort of set the standard in New Jersey in a different way.
I think that's true, but I do think United is gaining ground. So I can try to find the latest stats, but I think that Horizon's market share has diminished a little bit. But they're still the largest provider and they really do rule the negotiation process.
Yeah, I would say for our clientele in our area, this is Ashley Torres, that the majority of our clientele has Horizon. And we serve about 300 women and children in our area and about 100 fathers. And majority of the patients that we have in our location is Horizon. So I would say, yeah, they are pretty big in our area.
Thank you for that additional information. The next question is, in New Jersey, is there a standing recommendation that the MD must complete for the doula to bill?
Yes, I brought this up before. So yes, there is a recommendation. It's an NJ family care form that every doula needs to get signed. Well, actually every client needs to get signed. What I've done to work around this is that really the recommendation can be filled out by anyone who, any provider that has an NPI number. So you can technically go to your chiropractor or another nurse or someone else who is more, that you have a better relationship with, because a lot of times our families don't necessarily have the best relationships with their doctors. It's just the doctor that they had on their insurance. So, and a lot of those doctors are not amenable to doulas, but the recommendation does not have to be by their doctor. That's a big misunderstanding. And I think when more people know that, then they'll feel a little bit better about approaching different providers to kind of get that recommendation, because there are a lot of people who do want that service, but doctors have been a little bit hesitant.
Follow up.
But you do need to, yeah.
Oh, sorry. If the follow-up to that is, if any provider with an NPI can do it, why can't another doula?
Because a doula is not a medical physician. It needs to be someone who is that has a certain designation, and the doula is not a medical provider.
Thank you. So the next question is, can you talk a little bit about Medicaid dollars for facility fees and what consumers should know?
Oh, this is a hard one. Is this Jill?
Yes.
Because I teach childbirth education in an hour. So every Thursday I'm like all about prenatal cancer.
So facility fees, I should get you a real answer because I don't know as much about how they work in New Jersey. Facility fees are essentially, if you're getting care at a hospital owned facility versus a physician owned facility, it can be more expensive. And the facility can pass that cost on to the consumer. So because of the surprise billing legislation that was passed at the federal level, all entities that get Medicare dollars are supposed to provide that information upfront to all consumers. But there's obviously been like huge variation in compliance with that law. But you should be able to go on to, if you're going to a facility that is owned by a hospital and is able to charge facility fees, you should be able to go on up front and find out what those are by your insurance type, if they're following the law. But I'm happy to look into it, New Jersey, a little bit more, Jill, and get back to you.
And Jennifer provided a follow-up stating that facility fees is an issue for home birth provider. I'm assuming like midwives that provide home births. Excellent, thank you. The next question, are services from, I think this question was answered, so I'll read the question, but then read the answer that was provided. Are services from NJ's children's system of care in which of the NJ Family Care programs, the general NJ Family Care or the DDA one? The answer that was provided by Raquel is this: the children's system of care is a combination of NJ Family Care and other state funds. So I'll say that, and then if there's anything else to add to that, or in a follow-up question, please feel free to jump in. Okay, seems satisfied. So we'll move to the next question. Also responded to, where does case management fall in reimbursement through Medicaid? And other providers can bill Medicaid for case management services, nurses, for example. So we talked about that. The next question is what percentage of births is covered under straight Medicaid and percentage with New Jersey Family Care? If I'm saying this wrong, please forgive me. Is there one statistic that combines both the MCO and NJ Family Care and straight NJ Medicaid? Did I ask
That
that?
was my question, just because like we talk differently about like what's straight Medicaid and what's NJ Family Care, and just like, is there like from like, what's the most like, how should we be speaking about it as birth advocates and people in New Jersey? Is there an accurate way of communicating?
Unless Tatiana Raquel knows I don't know the answer to that offhand, but I'm very happy to look into it.
I'm so sorry. I was looking for information on the home birth bill.
So was I. Did you ask how do we advocate?
No, it's essentially like, you know how some women are only covered for pregnancy, or were only covered for pregnancy, so it's limited, and sometimes they're still in fee for service, they don't make it into a plan. So is there one combined statistic for how many births Medicaid pay for, not just through managed care? And I don't know the answer to that.
Yeah, I don't know either. I think that there's also like the presumptive eligibility folks, and I don't know where that data is. It's probably somewhere buried on the maternal website, the maternal data website, but I don't know where it is.
But I think the number that like 40% of births in the state are covered by Medicaid is a combined fee for service.
Okay.
So I think the more interesting thing would be to look at how many are fee for service versus, because there are far more in the fee for service pool than you would imagine. Because they maybe didn't seek care and they showed up for prenatal care, and then they showed up at the hospital for their birth.
Delivery,
Medicaid for the birth, there was no time to enroll them in a plan.
Right.
It takes about 30 days, or I forget how it works. There's like auto assignment after a certain number of days if you don't choose.
So I'm seeing a little bit about the home birth. It's being proposed by Brittany Timberlake. So Ms. Timberlake has been a controversial figure with New Jersey birth legislation, particularly with the doula registry legislation. There's a lot of pushback on that. And so I would be curious to see what the provisions are of this legislation, and if it does harm to midwives and doulas in ways that like kind of prevent them from doing their work in the ways that they see fit.
The malpractice liability insurance requirement is one of the reasons why the CPM groups have shared publicly in some midwifery work groups that they haven't like signed on to it. I don't want to speak for them, but just what they were saying publicly. And there's no Senate sponsor, so I don't think it's going anywhere.
Thanks, Jill. I appreciate the update. I've been out of the game for a bit.
Thank you for that. That makes me wonder if there's anything that we could do to perhaps push that conversation
Mhm.
of advocacy. So that's a conversation to have. Ashley, you asked a question, but I'm not sure that I captured the entire question. You wanted to know more about community health, I think community health workers. You could restate your question or provide some more context.
I think she provided the information once we were going down the slides about the different types of advocacy and different types that you can join. Just because she mentioned that during the first time of
Okay. All right.
get
Wonderful.
more insight on it, but she explained it. Thank you.
All right. No problem. I'm glad that the response was shared. The last question that I have is from Jennifer. So again, if I say something incorrectly, please feel free to respond. Can you say more about the pilot program and the incentives to clinicians for certain outcomes? Is there concern this could cause certain providers to turn away some high-risk potential patients or potential patients with less favorable social determinants of health to improve their outcomes? And Raquel did provide a response. So just wanted to make sure that that question was responded to fully, and if there's anything else that you wanted to ask.
I mean, I'll just say out loud what I said in the chat, which is that any value-based payment program runs the risk of what I would call creaming of patients in order to achieve the outcomes. My feeling is that weighing the pros and cons of value-based payment, if they move beyond a pilot and this becomes the way that New Jersey Medicaid reimburses for birth, then any Medicaid patient would, it would be impossible to cream, at least for the provider agencies, that at least if you accept any Medicaid patients. And while I think like you could then just say that that might put downward pressure on the providers to accept Medicaid patients, 40% of the state's births are Medicaid, so that would really not necessarily be a profit-wise decision for health systems to avoid that. And really the value-based arrangement of the episode of care is a richer, more flexible payment, and it's more favorable for providers to be paid under that arrangement because it gives them more flexibility as long as they achieve certain outcomes. So I think it's more attractive to providers. So in other value-based arrangements, I think there's a bigger risk than in a bundled episode of care, prenatal visit, prenatal protocol. But, not without risk, for sure.
Thank you. I appreciate that.
So we do have a few. That was the last question that I had that I captured. If I did not capture your question, please feel free to ask it at this time. Just open your mic and ask it at this time. Yeah. Any lingering
I have a
questions?
question. Can you guys hear me?
Yes. Mhm.
So I know that in the beginning of this year, there were some privatized MCOs that were offering doula care. Is there
Yes.
any correlation to what Medicaid is doing, or because I still feel like there's this extreme stigma for moms to actually admit that they are on Medicaid. And so when looking for doulas, what they're saying to me is like, hey, the question is, do you take my insurance? Now, how do I know like what you have and what you're doing? I mean, I do have within my agency, I do have two doulas who are individually, taking Medicaid, but as an agency, no, I'm not. And that's another wonderful thing to learn from this meeting, is that I can start to apply for that. But the other piece is they're just not naming the fact that they are on Medicaid.
Yeah.
And so there is this really weird kind of conversation of trying to pull that out. And the other thing too is that they won't even say it. They'll actually go, oh, I'm on New Jersey Family Care. And I go, oh, okay, well, that's what it is. You're right. So, but it really is, how do we break, and I don't know if we have an answer to this, but I'm just trying to figure out, how do we break the stigma of understanding that this is a service provided to you and that you should be able to get that and ask for it and be okay with actually mentioning it, because it's something that you're going to get, right? And I guess, I'm rambling right now, but that's really what I'm noticing in the last year, is trying to get that discernment between whether or not this is something that I have to do from a Medicaid lens, or something that I have to work with from, other privatized, insurance companies who are just offering this benefit. And that is become a little bit of a struggle. That's basically all I wanted to say in that, and whether or not we, if anybody had any ideas.
So I have a few things to say to that, and I know we're at have limited time, but I will say this. One, yes, the Horizon Blue Cross Blue Shield does offer doula reimbursements. The payments are basically double the amount of Medicaid NJ Family Care reimbursements. The way that you can get around this is that when you do intake, specify specifically the name of the insurance. So even before you have that initial call, because they'll get you on a call and then you won't be able to suss out like if you can even support them. So the way that I've done it, at least, is on that intake form, you list out, is it Horizon NJ Health or is it Horizon Blue Cross Blue Shield? They have to click one or the other. If they don't, then you don't know what insurance they have, and then you can't support them. Horizon Blue Cross Blue Shield is the commercial insurance, and then Horizon NJ Health is Medicaid. So that is one way to kind of get that information. The other thing is that, yes, you are qualified to become a doula agency. So I would go, if you want to go down this path, I would register your agency as a Medicaid agency, because what can happen next is that after you've registered as an NJ Family Care agency and you enroll with the MCOs, then you'll be able to enroll as a commercial provider with Horizon. And it seems like, from my experience, it seems like they prefer that you enroll as NJ Family Care before you enroll as Horizon Blue Cross Blue Shield. They want you kind of in the system. And
yes,
it just makes it easier. It makes it easier. It's not ideal because maybe you don't want to take on Horizon NJ Health just because the sheer volume that you will get is just Horizon. There's 1 in 3 people in New Jersey who have Horizon insurance, and you will get slammed with Horizon clients. So it's really important to distinguish that in the intake form.
Thank you, Tatiana.
I was just going to add, like, that's such a good explanation of the bureaucratic morass of the system. And I would just say that I feel like this is a really important point of advocacy, because we are really creating a 2-class system, right? We are saying if you come in through the commercial door, which, by the way, the commercial doula benefit for Horizon is only for people who bought on the individual market on the exchange. It's not for all commercial plans. So that's a pretty limited number of folks. It's my understanding from Horizon, I spoke to them about it last week, but I trust Tatiana's experience on the ground. You can go through from the commercial plan and decide to just add the Horizon NJ Health benefit if you want to. But we've created a 2-class system where the commercial plan is paying double, and and the Medicaid plan is paying half, and there's a lot more administrative challenges to submitting claims to Medicaid than maybe on the commercial side. So we're making it so that you're sitting face to face with a client, Michelle as a doula, and unable to serve them because of your realities as a provider, and yet that individual needs care. So I feel like it's a really important point of advocacy that there should be some parity of payment across the commercial and the Medicaid benefits, so that you are not, so that you're not having to discriminate essentially against clients who are on Medicaid.
Thank you for adding that. And this was a fantastic conversation. I learned a lot. I must say that I'm definitely not the one to know much about this topic, but I'm very happy that all of you, have been able to have a robust conversation. I just want to point out that in the chat that I did provide the little graphic of the work groups. It'll go out with the email as well, but in case you want to nominate yourself between today and tomorrow for one of the work groups, and please share with us if you do decide to be on one of those work groups as well. And thank you so much to our presenters, Elizabeth and Tatiana, for your work today and providing this very important information to the community. This information will be sent out to anyone who has registered, but I'll also send a link to our YouTube channel for you to share with any others that may find it helpful. And thank you all so much. Have a lovely weekend and a great holiday. Take care.
Thank you so much.
you.
Bye.